Hi, it's Professor McCroy, and I'm coming to you this week with topic 6, the neurologic system. Here are our objectives: to describe the techniques used to assess the neurologic system. Number 2, identify appropriate neurological assessment and cranial nerve assessment techniques for clients based on age, development, and other psychosocial or environmental variables. Number 3, differentiate between normal and abnormal neurological and cranial nerve assessment findings that require further evaluation. Number 4, document health history and key components of the neurological and cranial nerve assessments on the client record. The aging process causes atrophy and steady loss of neuron structure in the brain and the spinal cord. As you see in the picture, a healthy brain on the left and an unhealthy brain on the right. As a result, a few differences are noted. Number 1, decreased weight and volume of the brain. And number 2, the ventricles are expanded. And this is what you see in Alzheimer's disease. The loss of brain mass causes many older adults to have problems with their memory, usually over 65. They have a loss of muscle bulk. Their muscle tone in the face, neck, and spine decrease. They also have irregular pupil shape. With Alzheimer's disease, the brain may atrophy for years before it is noticeable. Remember, decreased brain volume is normal in healthy aging, and a distinction may be difficult to distinguish from Alzheimer's. Muscle tremors may occur in people who are over 65. You may notice them in the hands, the head, the jaw, along with dyskinesia, which is, repetitive facial grimacing. When the elderly are in good health, they walk just as well as someone who is younger. This slide shows the racial and ethnic disparities noted relative to strokes. 6% of American Indians or Alaskan Natives have had a stroke. 4% of African Americans and 2.5% of Hispanics. If you notice the deep purple, this is what is called the stroke belt, and it's 8 states that have increased stroke mortality rates. So when we talk about subjective data questions, what are some questions that you can think of in regards to these areas? Just take a minute and think of what you would ask, or what the patient, not what you would ask, I'm sorry, what the patient or client would say in regards to a headache. Maybe it's the worst headache I've ever had. I fell down and hit my head. I started having seizures a couple months ago. What are some things that you might ask them? When did the headaches start? How frequently do you have them? How would you rate your pain on a scale of 1 to 10? Do you have any aura or specific sensation prior to having a seizure? For head injury, where was the head hit when you fell? What happened? What was the situation? Did you lose consciousness? How long have you had tremors? What are there any specific location on your body that you have them? Are they in your hands, your face? Do you have difficulty swallowing? And some people may think that difficulty swallowing means that they're not able to swallow foods. But a good question to ask is, when you're eating or drinking, do you cough? Because that could be a sign of problems with swallowing. With numbness and tingling, does the numbness and tingling come and go? Is it constant? How long have you had it? Is it progressing? Is it getting worse? Is it moving to different parts of your body? Does it feel like pins and needles? Are you having difficulty walking, writing, keeping your balance? These are all questions that we ask when we're doing a neurologic assessment. Now, one thing I want to remind you all, you are the detective. I say this all the time. You are the detective. So that means you don't just take the answer that the client says, you ask further questions, especially if it's a very vague answer. You really want to elicit more conversation, more information about the situation. So here's some more questions that you would ask an aging adult um, about dizziness. Does it happen when you first get up in the morning? Um, is it when you go from a sitting to a standing position? If you bend over, when you're moving your head? When does the dizziness occur? Um, for men, do you ever get up at night and feel like you're going to faint when you're standing to urinate? Have you had any sudden vision changes or fleeting blindness? Did it occur along with weakness? Okay, let's talk about objective data. Screenings are completed on well persons who offer no subjective findings. So what do you want to check? 5 things. Mental status, okay? The cranial nerves, motor function, sensation, which is light touch, pain, temp at the toes, and then reflexes, the deep tendon reflexes. With the cranial nerves, you're not going to have to check all 12. You're going to check 2, 3, 4, 6, and 7. You want to integrate the neuro exam as you complete the head to toe assessment. An example of this would be testing the cranial nerves when you're assessing the head. Okay. When do you do neurologic recheck exams? It's when a person, let's say, for example, fell, lost consciousness, hit their head, and they've been admitted for observation. Then you are going to periodically, as assigned by the physician or your hospital policy, have neuro recheck examinations. Okay. So if a person um, has had severe headaches, um, um, a weakness of unknown origin, or loss of coordination, anything like that, or signs of neurologic dysfunction, that's when you're going to do a complete neurologic examination. A complete neural exam includes, like I said before, mental status, cranial nerves, motor system, the sensory system, and reflexes. Here's some equipment that you're going to need for a neuro exam. a pen light, tongue blade, cotton swab, cotton ball, a tuning fork, and a percussion hammer. So when we're looking at the cranial nerve 1, that's the olfactory, and it's not normally tested, okay? But what does it do? It tests smell. If someone's reporting a condition, when do you think you might find asymmetry with smell? Well, if the person has a sinus infection, and when I say asymmetry, I mean the inability to smell on one side, or they can smell really good on one side and the other side not so good. Some examples of that asymmetry would be a sinus infection or upper respiratory infection, where they have occluded passageways. A smoker, someone who uses illicit drugs like cocaine, or someone who has allergies. Cranial nerve 2 is the optic nerve. So you're going to check the pupils for size, equality, and reaction. You're also going to check the extraocular movements. Some abnormalities that you might notice are visual field loss, ptosis or drooping, and that happens with myasthenia gravis or cranial nerve 3 dysfunction. You may notice increased intracranial pressure, which would cause sudden, unilateral, dilated, non-reactive pupils. Strabismus, which is limited movement or crossed eyes, as you see in the lower right corner. Or nystagmus, which is involuntary eye movements. So when you assess nystagmus, you want to make sure, you want to note if it's in one eye or both eyes, if they have pendular movements, if the eyes jerk, and then if it's really severe or coarse, if it's medium or fine, if it fades after a few beats, or if it's constant or consistent. And which is the plane of movement? Does it roll around or rotary? Is it vertical, up and down, or horizontal, or a combination? So cranial nerve 5 is a trigeminal nerve. It is a motor and a sensory nerve. In order to test this nerve, you're going to have to test motor and sensory function. For motor function, you're going to palpate the temporal and the masseter muscles as you have the client clench their teeth. They should feel equally strong. And you shouldn't be able to separate the jaw by pushing down on the chin. It is not normal if you can separate the jaw. If they have pain when they're clenching, that is abnormal. Or if they have unilateral weakness or asymmetric jaw movement. When testing for sensory function, you're going to have the client close their eyes and you're going to use a cotton swab or a wisp to touch the face. You're going to touch the forehead, the cheeks, and the chin. And the client is to let you know when they feel that sensation of touch. What would be abnormal with that would be unequal sensation. When you're testing the corneal reflex, you want to make sure that if the person wears contact lenses, that they remove the contacts. Also, You want to make sure you don't touch the conjunctiva. You want to touch the cornea of the eye lightly from the side so you decrease defensive blinking. What should happen? The person should blink bilaterally normally. For cranial nerve 7, this is the facial nerve, and this tests motor function and sensory function. You should notice facial symmetry. Ask the person to smile or frown, close their eyes tightly where you can try to open them, lift their eyebrows, show their teeth, puff their cheeks. Then, while their cheeks are puffed, press the cheeks in to see if air escapes equally from both sides. For sensory function, which is not normally tested, you're going to test for taste. So you put a solution on a cotton tip applicator with sugar, salt, or lemon, and you touch it to the tongue, and they have to identify what it is. The acoustic nerve or vestibular cochlear nerve is cranial nerve 8. You're going to test hearing acuity by the ability to hear normal conversation and by the whispered voice test. The whispered voice test we'll go over in topic 7. For cranial nerves 9 and 10, the glossopharyngeal and the vagus nerves, you're going to test for motor function and sensory function. For motor function, you're going to depress the tongue with a tongue blade, and you're going to pay attention to the pharyngeal movement as the person says ah, or as a person yawns. The vulva and the soft palate should rise in the midline, and the tonsillar pillar should move medially. When you touch the posterior pharyngeal wall with a cotton applicator stick, you want to note the presence of sensation. You want to prevent them from gagging, if at all possible, and you want to note what the voice sounds like, if it's smooth or if it's strained. For cranial nerve 11, which is the spinal accessory nerve, you're going to check 2 things. You're going to have the client rotate their head forcibly against resistance to the side of the chin. So you're going to place your hand on one side of their face, and that's the way, in the direction they're going to turn their head. And they're going to do that to both sides. You're also going to have them shrug their shoulders against resistance with your hands on the shoulders, as you see in the picture here. The movements that they make should be equally as strong on both sides. With cranial nerve 12, this is the hypoglossal nerve. With this, you're going to, you're going to inspect the tongue. You shouldn't notice any wasting or tumors. You're going to have the person stick their tongue out, and you'll notice that the midline protrudes as they stick their tongue out. Then you're going to have them say light, tight, dynamite, and you're going to note the sounds of the letters L, T, D, and N, and they should be clear and distinct. This is an example of a drawing of the cranial nerves. When you get a chance, this is an exam on YouTube of the cranial nerves. You'll see an assessment. So with cranial nerves 1 and 2, with 1, you may note an abnormality, and that would be a decrease or a loss of smell bilaterally, as I said earlier. And then with cranial nerve 2, where the person loses part of their visual field. For cranial nerve 3, you may notice dilated pupils, ptosis, the eye is turned out, the inability to move the eye up and down or even in, or absent light reflex. For cranial nerve 4, they will not have the ability to look down or out. Cranial nerve 5, they will have an absence of touch and pain sensors, the inability to blink, and weak jaw muscles. For 6, they will have an inability to move laterally. For 7, asymmetric facial movement or no facial movement and a loss of teeth. That's for 7. For 8, a decrease or loss of hearing. 9, they won't have a gag reflex. For 10, the vulva deviates to the side, no gag reflex, and they'll have a hoarse or raspy voice. For 11, the spinal accessory nerve, they'll have absent movement of the sternomastoid or the trapezius muscles. Number 12, when you ask them to stick their tongue out, it won't be medial protrusion, it'll deviate to the side, or their tongue movement will be very slow. Muscle inspection, strength, and tone will be discussed further in detail in an upcoming topic, so we're not going to deal with that right now. For cerebellar function test, we're going to talk about gait or balance test. You want to watch your client walk 10 to 20 feet, turn, and come back to the starting point. Normally, you will see a person move with a sense of freedom. If you notice that they're stiff or they have staggering or a wide base of support, then that's an abnormal finding. If you notice that their arms are rigid and they don't have the normal swing of the arms, that's also an abnormal finding. You want to ask them to walk a straight line, heel to toe fashion. This is called tandem walking. If you notice that they can't stay in a straight line, that's abnormal. If they have to widen the base and they can't do heel to toe, that is abnormal, or if you notice that they lose their balance. For the Romberg's test, you're going to ask the person to stand up with their feet together and their arms at their sides. When they're stable, you're going to have them close their eyes and hold that position. You're going to wait about 20 seconds. Normally, they'll be able to maintain their posture and their balance. Rapid alternating movements. So with rapid alternating movements, you're going to have the patient sit with both hands on the knees, and you're going to have them pat the knees with their hands, lift their hands up, and then pat with the back side of their hands. And you're going to have them do this back and forth, and you're going to ask them to go faster and faster. You're going to ask the patient to do this in an increasingly higher speed. All right. So normally They should be able to do it rhythmic and at the same pace. The next thing is the finger test. And what they should be able to do with this, with their eyes open, is use their index finger to touch your finger and then touch their nose. And then do that back and forth, and it should be smooth and it should be accurate. Then, with the eyes closed, you're going to have them stretch out their arms, and then they are going to touch the tip of their nose with their index finger. Okay? And then the next test, and that should be smooth and accurate as well. And then the heel to shin, what they're going to do is you're going to have them lay supine, and they're going to place their heel on the opposite knee and then run it down the shin from the knee to the ankle. Normal response to this is moving it straight down from the knee to the shin. Some abnormalities in muscle tone would be flaccid muscles, spastic muscles, or rigid muscles, and Cogswell's rigidity, which is most commonly seen in Parkinson's disease. Here are some links for videos that you can watch for intention tremors, rest tremors, paralysis, and other abnormalities in muscle movement. Abnormal gait videos. Please make sure you watch these videos so that you can determine the difference between abnormal and normal. Some abnormal postures are decorticate rigidity, and you will note this with the upper extremities and the lower extremities. With the upper extremities, you'll notice flexions of the arm, wrist, and fingers, and also adduction of the arm. It'll be tight against the thorax. With the lower extremities, you'll notice extension, internal rotation, and plantar flexion. This indicates hemispheric lesion of the cerebral cortex. For decerebrate rigidity, the upper extremities are stiffly extended. They're adducted and internally rotated. The palms are pronated. The lower extremities are stiffly extended. You'll notice plantar flexion, the teeth clenched, hyperextended back. It is more ominous sign than decorticate rigidity, and it indicates a lesion on the brainstem at the midbrain or the upper pons. With these postures, the patient is unresponsive and has an altered level of consciousness. Flaccid quadriplegia is complete loss of muscle tone, and there's paralysis of all four extremities. With opisthotonos, it's a prolonged arching of the back, as you see in the picture here, with the head and heels bent backwards. It indicates meningeal irritation. So now we're going to assess the sensory system. You're going to be asking your client or your patient to identify different sensory stimuli. So that could be through pain with like a pinprick, light touch, or vibration. Also, you want to compare the sensations on the symmetric parts of the body. So when you find a definite decrease in sensation, you want to map it out, by systemic testing in that area. So you want to Proceed from the point of decreased sensation toward the sensitive area. Avoid asking leading questions. Can you feel this pinprick? Can you feel this, whatever it is you're using? Because you can't really get a true reading on that. So you want to make sure that you're not telling them when you're touching. Okay? The person's eyes should be closed during each of the tests. You want to take time to explain what will be happening and how you expect the person to respond. You want to do this prior to initiating the test. For the spinal thalamic tract, we're going to assess pain, and it's tested simply by using a sharp point and touching them with it with their eyes closed. All right. And you want to test it bilaterally. You're going to also test light touch. And you're going to take a cotton swab and you're going to touch them on different parts of their bodies. The arms, the hands, the chest, the thighs, the legs. Okay. And their eyes are to be closed again so that you can determine if they can actually feel the sensation. Again, you want to compare symmetric points. For the posterior column tract, we're going to test vibration first. And how do we do that? We take a tuning fork and you're going to use a low pitch tuning fork because the vibration has a slower decay, or it stops, has a longer time of the vibration. You're going to strike the tuning fork on the heel of your hand and hold the base on a bony surface of the fingers or the great toe. There's a great picture on in your book on page 646. And you're going to ask your client to let you know when they feel the vibration start and when the vibration stops. If they feel the vibration or normal buzzing sensation on the distal areas, you can assume that those proximal spots are normal and you don't have to go any further with the exam. You want to compare the right and the left sides. And then when we talk about position, you want to test the person's ability to perceive passive movements of the extremities. So what you're going to do is you're going to take the toe and you're going to move it up, you're going to move it down, and they need to tell you what position it's in. For tactile discrimination, we're going to test stereognosis, and the person basically needs to have a normal sense of touch in order for these tests to be accurate. So for stereognosis, what you're going to do is you're going to take a familiar object, a key, a coin, a pencil, something of that nature, and you're going to put it in the patient's or the client's hand, and they have to determine what it is with their eyes closed. And then with graphesthesia, this is the ability to read a number by having it traced on the skin. So what you're going to do is you're going to take your finger or you're going to take the backside of a pen and you're going to write in the palm of their hand with their eyes closed, and they have to tell you what number that is that you're drawing. For extension, you're going to touch both sides of the body at the same point and ask the person to state how many sensations are felt and where are they felt. And normally they can feel both sides. For point location, you're going to touch the skin and then stop and then tell the person to put your finger where you touch them. For deep tendon reflexes, you want to make sure that the limb is relaxed. If you don't have the limb relaxed, then you will not have an adequate reading of how brisk or flaccid the reflexes are. So what you want to do is make sure, like if you're using the lower extremities, you want to make sure they're dangling off of where the person is sitting. And you want to give a short, snappy blow of the reflex hammer to the insertion tendon of the muscle. When you see this, you're going to make sure you use just enough force to get a response. And you're going to compare the right and left sides. They should be equal. And the reflex response is graded on a 4-point scale. 0 is no response at all. +1 is diminished or low normal. +2 is average or normal. +3 is brisker than average. It could indicate disease, but it could be normal for that person. And then +4 is extremely brisk, and it's like hyperactive. And you see +4 with clonus, and that's where they have rapid contractions of the muscle. And here are those scales for you. So as you're testing the reflexes, you can test the bicep reflex, and the normal response to this contraction of biceps muscle, you'll see the contraction and you'll see the flexion of the forearm. For the triceps, you're going to see extension of the forearm. For the brachioradialis reflex, you're going to see flexion and supination of the forearm. For the quadriceps reflex, you're going to see extension of the lower leg. And for Achilles, is plantar flexion against your hand. For superficial reflexes, these are sensory receptors in the skin rather than in the muscles. And you'll notice a localized muscle contraction. For abdominal reflexes, the person will be in a supine position with the knees slightly bent, and you're going to use the handle of the reflex hammer to stroke the skin. You're going to move from each corner toward the midline at both the upper and lower abdominal levels. A normal response is ipsilateral contraction of the abdominal muscle. For the cremasteric reflex, on a male, you're going to lightly stroke the inner aspect of the thigh with the reflex hammer or the tongue blade. You're going to notice an elevation of the ipsilateral testicle. For the plantar reflex, a normal response is going to be plantar flexion of the toes and inversion and flexion of the forefoot. With the older adult or the aging adult, you're going to use the same exam as you would for younger adults. You may notice that they have decreased muscle bulk, as we talked at the beginning of this lecture. They may also have senile tremors. They are benign, so just pay attention to that and note it in your notes when you're assessing them. You may notice tremors of the hands, the head, or even tongue protrusion. It's not uncommon to note dyskinesias with the elderly. Okay. One thing that you will note that there will not be rigidity associated with it. Also, their gait may be slower and their balance may deviate from the midline. After 65 years of age, there is possibly a loss of sensation of vibration at the ankle. That's very common. They may have a loss of ankle jerk, or their tactile sensation may be impaired. Okay, you may need to use a stronger stimuli for light touch and definitely for pain. Um, Remember, with the aging adult, everything is slowing down, even though they may be very active. Your assessment will most likely be a little different than with a young adult. Okay, so their deep tendon reflexes are less brisk. Okay, um, and then their plantar reflex may be absent or difficult to interpret. And then the superficial abdominal reflexes may be absent. Okay. For clonus, you want to test this when the reflexes are hyperactive. So you want to support the lower leg in one of your hands, and with the other hand, you're going to move the foot up and down to relax the muscle, and then you're going to stretch the muscle by dorsiflexing the foot briskly, and you're going to hold it there. A normal response, nothing. But when there's clonus present, you're going to notice the contractions of the calf muscle, and you're going to see the movement of the foot like a jerking movement. Here is a video for full neuro exam. Please watch all the videos in this lecture because they are very pertinent to what you need to know. For a neurologic recheck, these are done based on the person's situation, and it's usually because there's been some type of trauma, or internal or external. They do need to be monitored closely, and you're looking for any signs of improvement or deterioration. These assessments or exams are completed, some every half an hour, some more frequently, just depending on the situation, some less frequently. Okay. Um, when you're talking about the neurologic exam, you may notice different abbreviations, and that's with level of consciousness, motor function, pupillary response, and their vital signs. So, with level of consciousness, or LOC, if there's a change, this is the most important factor in this examination. Any changes, good or bad, but you definitely need to document changes in level of consciousness. Okay, with motor function, you want to check voluntary responses by giving simple commands, because it's also going to validate their level of consciousness. When you are checking the pupils, you want to note the size and symmetry of the pupils and their reaction or lack of. You want to monitor the vital signs closely, and you want to use the Glasgow Coma scale to assess level of consciousness. So this is a Glasgow Coma scale. So it's monitoring 3 different things. One is eye-opening response. So if you call their name, do they open their eyes? Or if you tell them, do you have to tell them to open their eyes? If so, then you mark 3, or you know they are responding to speech. Okay. If you have to use pain stimuli, like a sternal rub, then you mark a 2. Or if there's no response, you mark a 1. All right. For motor response, do they obey commands? Are they, do they not obey commands, but they respond to pain? Or flexion, they're withdrawing. Okay. If you impute pain, Okay, like if you pinch them and they draw their hand back, um, do they have decorticate or decelerate posturing or no response at all? You mark that as well. With verbal response, if they're oriented and alert and they can answer your questions of level of consciousness or orientation, then you would mark 5. If they're a little confused, then you mark 4. If their speech is just flat out inappropriate, like in this example, it says, "What year is it?" And they say after lunch, then you will mark a 3. And if you cannot comprehend their speech, you will mark 2 and then no response. Normal is 15 for the Glasgow Coma Scale. Here's some sample charting. So make sure that you review the sample charting. In class, you'll be going over documentation, subjective and objective, and SOAP notes, and just being able to document what you've observed with your client or your patient. Thank you for taking this time to listen to this recorded lecture. God bless you. Have a great week.